Thank you very much, Mark. Good afternoon, everybody. As said, I'm Bernadette Hanney. I'm a head of hospital inspections in the Midlands region, and I also lead for the on urgent and emergency care. And I've got my colleague Prem with me. Prem can speak just at the moment, so I'll carry on and Prem can introduce himself when we get to his bit of the presentation. So what we've got is a presentation. If you could just move the slides on, please. That's going to cover driving improvement, and as you'll know, we published a document recently called Patient First, which Prem will talk to presently. If we can move on to the next slide, please. Over the last 4 years, so from the first winter, which went over 2016 to 2017, we worked with CQC enrolled Prem as our national professional advisor, and Prem researched extensively emergency care, and we developed a methodology for focused inspections of emergency departments that some of you might have been involved in as specialist advisors, and some of you might have had at one of these focused inspections. And we've done these focused inspections over the last 3 years. This is our 4th year of running them. And the way that we do that is by looking at trusts and then their locations, because obviously many trusts have more than one ED department, and we look at a number of safety metrics such as total time in ED, time to treatment, ambulance handovers, staffing ratios, etc. And we look to our regional colleagues for their local intelligence about what they might be getting for patient and staff concerns, and we look at that and we decide where we're going to inspect. So after at the end of each winter, we've produced a document. So as you'll see on the screen now, back in 2017, we produced Meeting the Quality Challenge. In 2018, we produced Under Pressure, and both those documents have had significant clinical involvement from people like yourselves, clinicians in the field. As we looked at what we might produce in 2019-20, we were then marching, as we know, earlier this year towards the pandemic. So we formed a group with the SPAs to particularly work on a document, and that's how Patient First came about. And this is really through these documents, through blogs that Ted Baker, our Chief Inspector, and Heidi Schmolt, our Deputy Chief Inspector, have produced. And we've recently been producing some podcasts. There's 3 on the screen there, and there's one due to come shortly on children and young people, paediatric care. So that's how we drive improvement. But I think it's really interesting that our inspections focused very much on individual departments, but our documents try and get more of that system responsibility. Because as we just heard Higgy say, ED is where the symptoms of pressure arise. And we have to be careful that our inspections aren't just treating the symptoms, that they're looking wider at the pressure in departments. So I'm just going to hand over to Prem now, and he's going to just talk about how we recognise that increasing pressure and driving improvements. And then I'll talk a bit more about how CQD works in a wider environment.
Bernadette, I think we may have been scuppered by the technology here, so we're not able to get Prem at this stage. So apologies for that.
Okay, so I will be a poor substitute for Prem, but I'll do my best.
Thank you very much.
So as I said, we have a range of specialist advisors who are generally from good and outstanding trusts who support our emergency department inspections. And there was a desire from many of them early in the pandemic to sort of increase that clinical engagement, and how could they share best practice both amongst themselves and the wider body of emergency departments. So we formed a National Emergency Medicine Specialist Advisor Forum, and as I say, some of you on the call may be members of that. And that, I really take my hat off to that group of clinicians. It's consultants, it's nurses, it's various people, the enthusiasm and the passion they bring, both to improve their own emergency department, but the wider system as well, is phenomenal. It's one of my favourite meetings we meet once a fortnight, of the fortnight, and they were instrumental in putting the patient first document together. To be honest, CQC was more as of a signposter and a collator. It came from the clinicians and for the clinicians. That's how it started. But then we went on to consider, actually, just as I've said, issues in ED such as overcrowding aren't an ED problem. They are a problem for ED, but they're a system problem that the system the system needs to address. So that's why we widened it out and tried to get patient first, actually saying, you know, it's a trust issue, it's an ED issue, it's a hospital issue, it's a trust issue, it's a wider system issue. So there's actions for all there. So that's why the patient first document, how it came about. And there's some work going on now that lots of trusts that we speak to around the country are developing various checklists and pro formas and all sorts of things to do, if you like, a bit of a gap analysis on their organisation. But again, we think it's absolutely key that just isn't ED departments developing that. It's actually what's the trust responsibility, what's the system responsibility there. So just to move on to something else that we were asked in the development of Patient First, and I get asked quite frequently, and that is what Higgy's just alluded to it, but I often get asked what's CQC's position on corridor care. Now it's what's CQC's position on ambulance patients being delayed in the back of ambulances. And if we go back to the first of those documents, that I alluded to earlier, the second one, Under Pressure in 2018, one of the things CQC said in that document, and I quote, is patients should not be cared for in an unsuitable place, such as an ED corridor or in an ambulance in a hospital forecourt. And our view on that is as strong today as it is now. And what we see when we do go out and inspect is the reality is there is overcrowding and patients are still being cared for in both those environments. But what we expect to see is a risk assessment of why that patient's been cared for in that place at that time. So to have an escalation policy that says if this, that and the other happens, patients will be kept in the corridor, in the ambulance, actually is not acceptable, because there'll be different pressures in different parts of the hospital, the trust and indeed the system at different times. So it's very difficult, makes it very difficult to write an escalation policy, but you can't have a one size fits all in these circumstances. So that's just where our position lies on that. But as I've alluded to, our inspections are very much focused on the ED department, but we felt it was very important to actually say, so what is the trust doing to support both the urgent and emergency care department and also the system? So whilst there are patients in the back of ambulances, those ambulances are not getting out into the system to care for somebody who actually may be more seriously ill than some of the patients in the ambulance waiting to get into the ED. So from this year, we had a trust level conversation with every with executives, and some of you might have been involved in those conversations, with every trust that runs a type 1 ED on emergency care, and those took place in October and November. So we're just analysing the findings of that. But part of that formalising it, because quite often we've had those conversations in more of an informal way over the last 3 years, was to formalise it and actually drill down into what support is the executive team and the wider system giving emergency departments. So there'll be some output from findings from those coming later. We also, I mentioned earlier that we designed some metrics to identify trusts at risk of overcrowding and safety concerns. And what we're finding this year is those those metrics have served quite well over the last few years, where we've gone to trusts in our that we've thought were going to be at risk of crowding and safety issues. Actually, when we've gone, we've often found that that's what we found on inspection. But we're in a very, very different world this year, where information that we've got, if it isn't almost weekly data, it's kind of out of date due to the pressures that are changing so rapidly at the moment. So we're evolving those metrics, but the importance of combining those with local knowledge. So we look to the inspectors to give us information on whistleblowing and serious incidents, and if we've got staffing concerns, to put all that into the pot. We are increasing our engagement with ambulance trusts. Ambulance trusts can tell you on a daily, hourly, almost minutely position of some of the systems in some of the pressures in the system. So we've really increased our engagement with them, and we're having a similar trust level conversation with each of the 10 ambulance services to understand their version of the urgent and emergency care risks. And we're looking, as some of you might have also been involved, we did some provider collaborative reviews a few weeks ago that looked at the system view of urgent and emergency care. So it wasn't just about hospitally interviewed people from adult social care, people from primary medical services, and to get that system review. And certainly when we inspect our emergency departments, our regulatory role is to take enforcement action, but to be honest, quite often it needs the system to come together to resolve those issues, or help resolve those issues for that emergency department. So it's often that after such an inspection, if we find concerns, we'll hold a risk summit to bring all those partners in together to support the area to improve. I couldn't leave here today without saying that we do at CQC recognise the pressures and the burdens of inspections. Nobody particularly wants to see CQC probably at any time, but certainly not at the moment where everybody's under stress. But equally, we do have a legal requirement to act where patient and staff safety is absolutely paramount. And so if our metrics are showing that there's concern and we're not able to get assurance any other way, then we will use our powers of inspection. But when we do inspect, this is the sort of thing that we look at. So the model we use for our focused inspections is based on these 5 things. So clinical care, infection prevention control, patient flow, workforce and leadership and culture. And you'll see a lot of those, well, if not all of those items are contained within the patient first documents. Infection control we have enhanced this year. We didn't have such a high focus on infection prevention control, but obviously that's a key issue this year, and we will from this year keep evolving our model. So who knows where we'll be this time next year, but we'll evolve our model to look at that, and also we continually looking at our model to see how we can involve those system issues. So I think what I come back to is we want to understand, in summary, how the ED department, the trust and the system escalate their urgent and emergency concerns. And what I wanted to make you all aware of is how CQC escalates it to decide where we need to put our inspection and resource. But it isn't exclusively about inspections. There are all these other things going on as well.